Good afternoon, everyone, and thank you for Ohio's Future first in our series of Friday afternoon webinars. My name is Danny Carlson. I am our communications director. Thank you again, everyone, for taking the time to join us this afternoon. I'm going to hand things over to my colleague Tara Britton in just a second, but I did want to let everyone know if you do have any questions for our presenters today, please feel free to type them in the attendee chat box, and we will be sure to answer as many questions as we can. And now I'm going to turn things over to Tara.
Thanks so much, Danny. Thank you all for joining us today. And we're really pleased that you all are able to join us quickly, and really hope that this will be a lot of great information for you. I'm with the Center for Community Solutions. As Danny mentioned, we're a nonpartisan nonprofit that improves health, social, and economic conditions through nonpartisan research, policy analysis, communications, and advocacy. You'll see on the slide there ways to connect with our website, where we have a whole host of information on all of our priority areas. We also have a COVID-19 resource page where we've been housing all of the information that we've been pulling together as it relates to how policies and programs are impacted by the pandemic. I'm going to turn it over to Kelsey Bergfeld with Advocates for Ohio's Future, who will introduce AOF and our presenters.
Thanks, Tara. Good afternoon, everyone. My name is Kelsey Bergfeld. I'm the Coalition Manager of Advocates for Ohio's Future. We are a nonprofit, nonpartisan coalition of over 500 health and human service policy experts, providers, as well as advocacy organizations throughout the state. We cover a broad range of issues pertaining to health and human services policy, including healthcare access, food security, safe and affordable housing, issues pertaining to older adults, as well as those with disabilities. So we, our state partners come together, we discuss policy and budget solutions to make sure that all Ohioans, especially our most vulnerable, live their best lives as easily as possible. And we know that's especially important during these challenging times. We are very excited to have two national policy experts today join us from Community Catalyst. Community Catalyst is a national nonprofit advocacy organization. They work to build the consumer and community leadership that is required to transform the American healthcare system. Today, our two presenters are Rachel Brill. She is the Senior Policy Analyst for Together for Medicaid, and Eva Marie Stahl, the Associate Director of Policy for the Children's Health Initiative. We are very excited to have you both on today, and feel free to kick it off when you're ready.
Awesome. Hi, everyone. My name's Eva Stahl, and I'm with Community Catalyst. And I'm delighted to be here with you today with Rochelle, my colleague. We're going to sort of spin through some of the, next slide. Why don't you go ahead and jump forward to our agenda. So if you take a look at our agenda, we're going to do a quick overview of some of the federal legislation that has passed recently. These are pretty heavy slides. I'll give you fair warning. They provide a lot of content so that hopefully you can go back and sift through them to get an idea of the breadth of the legislation that was passed over 3 different phases. So we'll try to sort of hit the high points for you over the next couple of minutes. And then Rochelle is going to walk you through state opportunities. So once we get through understanding really how the federal landscape and the policy opportunities have shifted, then what are the doorways we can walk through as states to really maximize these opportunities, leverage them to ensure that people are getting the coverage, care, and access to basic needs and services to be healthy and stay well. So with that, why don't I kick us off with the next slide, and we'll start with the federal legislation. So as folks, there we go. As folks probably know, there was rapidly moving legislation in a number of different phases. The most recent was on March 27th. Congress passed a third stimulus package. This was HR 748. which is also known as the CARES Act. It's also referred to as C3, COVID number 3 package. This is the third package to address the pandemic, and it's about $2 trillion in government response. It adds to our second package that really focused on paid leave and healthcare response, and that was advanced by the House and passed by the Senate on March 18th. That was called the Families First Coronavirus Response Act. We refer to it as C2, and for you children's advocates out there, you know how confusing it is to have another bill called Families First, but this is about COVID and its response. So with respect to the third $2 trillion legislation, that really includes unemployment and benefits, insurance, paid leave, loans and aid to industries, including airlines, tax credits, emergency assistance for schools, as well as, most notably, cash checks to most Americans. The healthcare provisions of the CARES Act, or the C3, really focuses on $100 billion that's directed to healthcare providers, so hospitals, public entities, non-for-profit entities, Medicare, and Medicaid-enrolled suppliers and institutional providers. It also includes $150 billion in what we call the Coronavirus Relief Fund for state, tribal, and local governments. So we're going to tick through what these bills focus on, and as I go through the slides, you'll see that I notate whether something is C2 or C3, and that's to help you understand which package it was a part of. What I haven't lifted up yet, of course, is this first phase, which was largely funding of about $8 billion for HHS and CDC to really focus on supplies. So that was a couple of weeks ago, that first phase. Next slide. So here you can see through the phase 1 through 3, it's just a deeper dive into the different sectors and dimensions that all of these different bills touch. They range from the health system investment to student loans and some minimal funding for elections. So it really crosses just a broad portfolio of needs. The focus of C2 was really Medicaid and paid leave with some social support funding, but really the C3 focus was really on economic stimulus. So this was about bailouts for corporations, unemployment insurance, and such. We got some positive provisions on state stabilization in that third package, but we also know that the health investment was just not enough, nor was it enough for social services. And there already is discussion about additional needs that we've heard from Speaker Pelosi and her recent comments about working to develop a fourth response, which will be called C4. Next slide. So let's just take a quick sweep of the health system investments. And these are really top line. So it's not inclusive of all provisions, but it gives you a little bit of a flavor. So really the investments here are important to helping providers, hospitals, and frontline workers stay funded as their workload shifts. So think about all of the canceled elective surgeries and the shifting of work. It also addresses the building out of capacity needed to deal with the patient surges. For example, I live, and so does Rochelle, in Massachusetts, and we're about to surge in the next couple of weeks and have turned convention centers and filled them with beds as a way to address our capacity concerns. So underlying this need is really a deeper problem. It's about our system readiness and our bed capacity and how we respond to these pandemics. Another important element of the federal legislation is around telehealth. So for some providers and systems and areas of the country, this is a huge lift. So think about, the rural parts of Ohio, for example. But we know that it's really important to help these groups and providers ramp up their ability to provide telehealth services. So the C3 bill makes significant investment in rural hospitals, as well as opening up the door a little wider for substance use telehealth opportunities and more flexibility across Medicare and other options through 1135 waivers, they're called. Rochelle's going to address these in a little bit. That gives us the opportunity for states to address some telehealth restrictions and open up the door for more of that type of care. Finally, community health centers did get their funding. Many of you might recall that there were a group of healthcare extenders, they were called. Community health centers is one of them that needed to be funded by May of this year. Community health centers did get their funding, and they were funded through November of this year. And they also received a boost on top of this, as well as a provision that permits payment for community health centers to use telehealth and Medicare. A quick note about the $150 billion in stabilization funds, termed the Coronavirus Relief Fund. This really allows the Treasury to make payments to states and tribal governments and local governments with populations of 500,000 or more. There's a formula based on the population for these payments, and any local allocations are subtracted from state allotments. Next slide. So another important dive to take would be around Medicaid, which we know is one of the most important programs we have to scale up and respond to this pandemic. And the majority of Medicaid-related changes were instituted in the C2 package. Disappointingly, they were not shored up in the C3 package, which leaves work for us to do. A key change is a 6.2 percentage point boost in the federal match, or what we term FMAP. As many of you know, the federal government uses a formula to determine the percentage of federal match to state investment in Medicaid. So similar to 2009 in that recovery package, which is termed ARA, states will receive a boost in their matching. So this does not apply to expansion populations, and the funding is conditioned on maintaining your Medicaid program. This is termed the maintenance of effort. States cannot tinker with their eligibility and throw people off Medicaid if they choose to accept these funds. So other changes to Medicaid in that C2 package offer a pathway to cover the uninsured for COVID testing and treatment by extending temporary Medicaid coverage to them during the pandemic. And again, Rochelle will talk about some of the waivers and tools used to do this, and we'll discuss it later in the presentation. CMS did release and is continuing to release a boatload of guidance. And when we send around the presentation afterwards, there will be some links in there so you can see what some of that guidance and FAQs look like. Next slide. So the next real bucket that's worth mentioning is around testing and treatment. And this really gets much more complicated than it looks. See, is the slide not changing quite yet? There we go. Oh, too fast. One back, the one that says testing and treatment. Thanks, Danny. So the testing and treatment is a complicated issue because you have different phases of legislation that address different elements. So for example, in the first package, it extended protections and cost-sharing protections around testing, but not necessarily treatment. So it's just important to tease these apart and continue to monitor them. And another added element, of course, is access to vaccines. So with that said, the C2 package did extend protections for cost sharing and private insurance, but the third package had to go back and clarify what types of diagnostic tests and what the pricing would be. And there do remain some loopholes that are really concerning. So I think that as we continue to think about this issue, we need to play it out. So for example, if you get tested and you're negative, you're still saddled with those costs of getting tested, right? But if you get tested and you're positive, you still have to absorb the cost of treatment. So clearly there's a lot more work to do. Medicaid recipients are in a much better position if their state chooses to accept enhanced funding because they'll have cost-sharing protections for both testing and treatment. So keep in mind that you need to be in an eligibility category of Medicaid. So for many of our immigrant populations, they are left out of this. This is another important thing to point out with COVID testing and treatment, that those who do leverage Medicaid, these elements are not subject to public charge, which is an important message we continue to communicate to our communities. Next slide. So with respect to food and housing assistance, the bill includes over $15 billion more for SNAP to cover projected increases in applications and the cost. This came through the C2, I believe, package with some in C3. So for some reference, you know, when benefits were temporarily boosted in the ARA, which was the American Recovery and Reinvestment Act, that's the one of 2009, research really showed that during economic downturn, every dollar of SNAP benefits led to between $1.50 and $1.80 in economic activity. We continue to remind stakeholders and government decision makers that investments in SNAP, investments in Medicaid are really good programs to scale up and quickly drive revenue back into state budgets. So they are economic stimulus. With respect to housing, There are a lot of things that are left undone. While those federally backed mortgages and loans are protected to a certain degree to protect families from housing insecurity, we know that we still need nationwide bans on eviction proceedings and other measures like emergency funds to protect people that are in housing crises. And just a quick comment about WIC and some of the monies that are directed toward helping families through this difficult time. WIC, along with another host of programs, are moving virtually. So we're seeing enrollment move online, and Rochelle can speak a little bit about some of those movements in Medicaid and how important it is to support those transitions in the coming weeks. Next slide. So the next two slides really address the paid leave and unemployment insurance, as well as the cash payments, which is a little bit outside of our wheelhouse. So mostly this is just for your information, but I think it's important to understand what tools are available to families. So for example, in the C2 or the second package, we know that certain employers need to provide employees with sick pay starting on April 1, and really focuses on businesses that are fewer than 500 employees, and providing them with paid leave either through their own health needs or to care for family members. This includes 2 weeks of paid sick leave at the employee's regular rate, also sick leave at 2/3 the employer regular rate if they're unable to work because they have to care for an individual. So it can be really helpful for families, and it's important just to understand how those mechanisms are going to work in the state. We know that there's a backlog right now as people are trying to access the unemployment insurance at the moment. So paid sick leave is one lever that folks can use. With respect to the unemployment insurance, in an effort to fill the gap between that paycheck, right, and the unemployment benefits, the CARES Act, which is the third iteration, provides employees with an extra $600 a week in unemployment benefits. What's nice about this is that it's an additional 13 weeks of payments, and it also includes gig workers or those that typically don't qualify for unemployment insurance. Next slide. And then finally, I would say on the cash support, it's pretty straightforward, although we're hearing that there are hiccups in the ability to push out funds to families at the moment. There's a $1,200 payment per eligible adult, $500 for dependent child under 17, right? And taxable income is not required to claim the benefit, but you do have to have a work-eligible Social Security number and cannot be a dependent of another tax filer. We just continue to ask people to monitor this. So it's a really important component of making sure people have the money that they need, along with other wraparound protections to make sure that they can be paying not just paying their bills, but feeding their families and staying healthy. Next slide. So I know I'm spinning through these really quickly, and that's challenging, but I will tell you that you'll have access to some good analyses following the presentation that will make sure that you can tap into, as well as some infographics that provide details. I think for us, next slide, the big question is this enough? And as we talk to our state partners and listen to local partners and community-based partners, it's very clear that it's not. Next slide. So we're very focused on, where we see the advocacy going in the next couple of weeks as a conversation kicks up about what needs to be in the fourth package. So I'm just going to preview for you, next slide, where we see some holes that need to be addressed. So clearly we need more financial support. So one more slide, Danny, to the C4. There you go. So really, where do we need more support? So financial support is clearly incredibly important. We are seeing millions of people attempting to claim unemployment. We know that it's going to take a hit on our state budgets, and this is like something we've never seen before. So clearly, we need to get revenue to states quickly. We are strong believers that SNAP and Medicaid are two forms of revenue to move very quickly and scale up and infuse into state budgets. In addition, we know that there continue to be holes around workforce protections. We're hearing this across the news and the media, as well as knowing that we need to have increased access to coverage and care. And not just getting access to treatment, for example, for essential workers that might be in under-resourced communities and not have access to testing or treatment in the same way that wealthier spaces do, but also about making sure that that treatment has no cost sharing. So really to fill those holes around private insurance and other types of plans to make sure that we're not saddling people with debt. Clearly, we need our social service organizations to be held and funded and supported to make sure that they have the tools they need to provide services to the many individuals and families that need our help right now. So those are just a few examples. And then, you know, if we dig a little deeper, Danny, to the next slide. I know we're short on time, so I want to hand it over to Rochelle. But when you receive this, these sort of highlight, you can see some of the things that we as an organization are asking for. And we certainly want to hear a lot more from other organizations about what they're seeing on the ground and get feedback about where you see additional needs, because we know that there are many. So I'm going to stop right there and hand it over to Rochelle, who is going to talk a little bit about some of the state opportunities to give you an idea of how Ohio, for example, can leverage these tools to get help to where help is needed.
Thanks, Eva. Danny, we can go on to the next slide, to my section. And folks, feel free to interrupt me if you're having trouble hearing me. But good afternoon, everyone. Once again, my name is Rochelle Brill. I'm a senior policy analyst at Community Catalyst, and I'm going to be giving a brief overview of policy options that state Medicaid programs have at their disposal to address the ongoing COVID-19 crisis. As some of you may know, but some of you may not, Community Catalyst works with state-based healthcare advocacy organizations in about 40 states. So in the past few weeks, we've been able to track how different Medicaid programs are addressing the coronavirus crisis. And one of the states that I work in and where Community Catalyst is based is Massachusetts. And so that's been my main source of intel regarding how a state Medicaid program is addressing COVID-19. So I'll be using Massachusetts a lot in my examples, but then we also have some intel and information from other states. And I also just want to say at the outset that I'll first be providing an overview of what states are doing, then a look into how they've been able to do it, what levers they're pulling on, including some new options that are available specifically and only in times of emergency, and then an overview of what we want states to be doing, what we think advocates could or should ask of their state Medicaid programs to do in addition to what they're already doing. And some of those things can be achieved through the new emergency-specific policy levers, but then some of them can be achieved through policy options that are already and have always been available to states. They're not new options. And so I'll just distinguish those during the presentation. Now we can go on to the next slide. So first things first, what are state Medicaid programs doing right now to help their residents during this crisis? One thing is that they're making it easier for current Medicaid enrollees to keep their coverage. They're doing this in a few ways by waiving some of the administrative requirements, like submitting verification documentation, being required to renew coverage at least once a year, even waiving certain premium and other cost-sharing requirements if a Medicaid program has those. Another thing state Medicaid programs are doing is expanding coverage, both presumptive eligibility so that individuals can receive healthcare more quickly and easily, as well as expanding eligibility for home and community-based service waiver programs. And then lastly, they're expanding access to healthcare services overall by making it easier for providers to see and serve Medicaid patients. So making it easier for them to become a Medicaid billed provider, deliver care more quickly and easily, such as through alternate settings or through telehealth, and then in getting paid more quickly and easily for delivering that care. Next slide, please. So let's now move into how state Medicaid programs are doing these things. When an emergency or natural disaster strikes and the president declares a state of emergency, states have the option to submit an emergency-specific waiver called an 1135 waiver. Right now, the Centers for Medicare and Medicaid Services are fast-tracking approval of these waivers based on a checklist or a template that they're providing. And so as an example, Massachusetts submitted one recently, and they didn't get everything that they asked for. They only got approved things that were on the checklist, and then they even received approval for things that they didn't ask for because they were on the checklist. So right now, they're fast-tracking approval of these waivers and have approved about 40 so far. I would say the one sentence description that I'll give for these waivers is that it makes it easier for Medicaid patients to receive health care more quickly and easily by waiving a lot of bureaucratic or administrative requirements for providers to join the Medicaid program. So a lot of 35 waivers also waive a lot of requirements for the federal government to have to approve certain changes so that states can go ahead and make those changes more easily without federal approval. And then there are a few, but not a lot, of consumer protections that can be put in place through an 1135 waiver, such as extending the amount of time a Medicaid enrollee has to request a fair hearing. So back to Massachusetts, the Massachusetts Medicaid program called MassHealth submitted a waiver to waive certain provider registration and training and practice requirements so that physician assistants can practice more easily without physician oversight, so that home health aides can provide care without meeting all of the training requirements, so that lab specimens can be drawn or taken by more types of hospital staff, so that hospitals and nursing homes can adjust their staffing ratios more easily. Things that just open it up and make it more easily for providers to deliver care. Another option that's become available to states during times of emergency is to submit an Appendix K to their Section 1915C Home and Community-Based Service Waiver. Appendix K, like the 1135, is meant to specifically address situations of emergency. Not surprisingly, states can use Appendix Ks to expand or increase access to home and community-based services. And they can do that by increasing eligibility, increasing the types of services that can be provided, such as Meals on Wheels, or otherwise just increasing the benefits and services that individuals can receive so that individuals can receive care at home, such as even allowing a family caregiver to be reimbursed for providing services. If, for example, let's say an LTSS coordinator can't come to the house anymore due to social distancing rules. The other options on this list are ones that are always available to states if they want to make some type of change to their Medicaid program, but I just want to quickly review how states are using them in this crisis. So Medicaid 1115 waivers are traditionally used by states who want to make changes to eligibility or to care delivery. And right now, the Centers for Medicare and Medicaid Services is providing a checklist or template similar to 1135 that allows states to make changes that mainly fall into the first bucket I mentioned earlier of making it easier for Medicaid enrollees to keep their coverage. So for example, Illinois submitted an 1115 recently to allow individuals to apply for coverage without needing to submit documentation to verify their immigration or citizenship status. And other states have submitted waivers to waive the requirement that individuals need to submit a renewal once a year. Medicaid state plan amendments, again, are always available to states and are a big avenue for making changes. Once again, CMS is providing a disaster-specific state plan amendment template, and this is how a lot of states have been proposing to expand presumptive eligibility, either by expanding the categories of Medicaid enrollees who can get presumptive eligibility, or the types of entities who can make those determinations. So allowing the state itself to make a presumptive eligibility determination, to allowing case managers, hospice centers, nursing homes to also be able to make those determinations in addition to hospitals. And then last but not least, regulations or sub-regulatory guidance is also how a lot of states have been making changes, particularly with respect to providing services through telehealth. The Massachusetts Medicaid program has released a lot of provider bulletins and guidance about expanding access to telehealth services recently. So making it easier for providers to be a provider that can bill for telehealth, changing the billing codes to expand, to make more services available as a telehealth billable service. Really a lot of guidance has come out recently in Massachusetts to make telehealth more available. Let's go on to the next slide. So since 1135s, I would say, are the newest or largest development for ways states can respond to COVID-19, I wanted to show a quick graphic of which states have received approval for them so far. And you'll notice that Ohio is not on this list yet. I'm not sure why. Perhaps there are others on the call who might have more intel or information on that. But right now, say the vast majority of states have applied for and received approval for 1135 waivers. And then let's go on to the next slide. So that's my review of what states are doing, but what do we think states could or should be doing, and what can advocates ask them to do? The Community Catalyst policy team put together a list of policy priorities that we think advocates can use to make asks of their Medicaid programs right now. And this is what we came up with. As you'll notice, though, many states are already doing these things, and they fall into the buckets of things that they're already able to do through the levers I just walked through, like preserving coverage, ensuring access to care. But one of the policy priorities we wanted to add is around health equity and racial justice, because those are policy priorities that are very important to us. And since we think this public health crisis will likely highlight, even exacerbate, some of the disparities that already exist in our healthcare system and in our country, we think it's important that states take steps to center health equity and justice in their policymaking at this time. And we think they can do so by doing things like ensuring medical triage guidelines or emergency operations guidelines don't discriminate against individuals with complex health and social needs. And we also think states should be expanding access to telehealth services delivered specifically by providers who have been shown to reduce health disparities, such as doulas, dental therapists, community health workers, peer support specialists, providers that often are representative of and reflective of the communities they serve. So overall, our principles are to preserve coverage, ensure access to care for vulnerable populations, such as individuals with disabilities, older adults, individuals who need substance use disorders, individuals who need reproductive health care, reach the remaining uninsured by expanding access, and ensure health equity and health justice are at the center of any healthcare policy decision-making at this time. So that concludes the portion of my presentation, but Eva and I are happy to take questions now or offline, and we've provided our email addresses on one of the following slides. So thank you so much for having us today, and we're happy to take any and all questions.
So we have had several questions come in as you guys were presenting. First question is, how does the COVID experience shape the Medicaid for All debate?
That's not a big question, right? This is Eva. So I think that we have yet to see how it shapes the debate, but I think that, you know, we're thinking, at least at our organization, around short, medium, and long term in terms of, you know, health system response. So when we say the term Medicare for All, it's not necessarily, it's more of a slogan than an actual plan, but I think it refers to more moving toward universal coverage, right? I think that we're in a moment where we're seeing the holes in our system, of which there are many, and that is incredibly frustrating. And so it's about how we use the moment and whether we can really build collective power to shift the conversation to taking advantage of this, to really shift the conversation in the right direction so that we are more nimbly able to respond to pandemics such as these. I don't know if you want to add anything, Rochelle.
No, I think that's right. I myself, personally, taking off my community catalyst hat, was having really mixed thoughts on this because I think there's a view that it would definitely, having any type of Medicare for All would expand access. We wouldn't be in a situation where individuals were having trouble accessing health coverage and likely wouldn't be getting exorbitant bills for treatment and not knowing why. But then definitely in the early weeks when we saw government being slow to respond, that's when I thought, I don't know that this is I'm not sure which way it cuts, or if it definitely cuts in favor of Medicare for All.
The next question. Oh, sorry. No, I was going to move on to the next question, unless you want. Okay. So the next question has to do with FMLA leave, and there has been some discussion in the chat box about this. But question seems to be about if there's an unintended consequence to the expansion of the FMLA expansion, that people are now not allowed to take paid leave time, but they have to take FMLA time and only get 2/3 of their pay because they're caring for kids and caring for kids with disabilities. I'm not sure if you guys have heard anything about this or can comment.
So I did see that flag and responded to it on the chat box that that's something I definitely want to take back to some of our groups that do advocacy for children with special needs and their families, because that's a pretty upsetting flaw if that's the case. And I think it was Teresa that brought that up. So we're definitely going to take that back to our advocate folks and do a little bit of digging about that. But it is written into the guidance that it is 2/3 of pay, so I can see where that issue would come up, but it doesn't seem like it should. So we'll take a closer look at that and get back to you.
Great. Next question. Under the CARES Act, do you have to meet a low-income household eligibility? And has that changed to be eligible for Medicaid to cover COVID-19 expenses?
So I don't know if you can speak to that, Rochelle, about, I think the question is related to MAGI, probably, right? And so, how we're categorizing folks in terms of being able to be eligible for Medicaid, but my understanding that it does not change that.
Yes, I don't think the CARES Act or any of the packages have changed the income eligibility thresholds for any of the Medicaid categories.
Right.
I might be misspeaking, so correct me if I'm wrong, Eva, but did the Family First bill have a provision saying allowing any uninsured resident in a state to enroll in Medicaid almost regardless of their income?
So it is, yes, it is about, if you have, proof of, there are a couple of, caveats and conditions for being classified as uninsured, but it is a mechanism that the state has to leverage in order to cover uninsured folks. So
I was in a meeting.
Go ahead.
No, go ahead. I was just going to say, I was in a meeting with MassHealth. The Massachusetts Medicaid program was talking about this, and they just said they have no idea how to operationalize that. They have no idea how to find an uninsured person and enroll them in Medicaid without having them apply. So, yeah, they just said that's great. We're happy to do that. We have no idea how to operationalize that.
And I think that is, that's not surprising and is a conundrum that I think a lot of states are feeling, that it sounds really good on legislative paper, but the operationalizing of all these different things is what's happening really rapidly, and states are just trying to navigate and figure out how to do this.
The next question we have, public transportation received $25 billion in funding from COVID-19. I assume the CARES Act is what the questioner meant. How and where will that money be allocated, and how can we advocate to ensure those funds intersect with the healthcare system, since transportation is a vital social determinant of health?
Rochelle, do you know anything about the transportation provisions as they relate to Medicaid? I don't think there is any. I think that we're probably not experts on transportation enough to be able to speak to that. But my understanding is they're probably allotted to states similar to how the stabilization funds are. So that would be a state determination about how they are spent. And whether or not that affects the Medicaid, option of Medicaid funded transportation, I think is unclear whether or not they're correlated or connected in some way.
Yeah, I think that's right.
Towards Medicaid eligibility. Does stimulus money count towards Medicaid eligibility?
No, it does not. Keep that one simple.
I was going to say fast answer, so now we can move on to the next one. Does a stimulus check get taken if you owe child support?
Yeah, I thought that was an interesting, and I think somebody in the chat box actually knew the answer. I did not know the answer. So that was, I think, what did it say in the chat box, Danny? Can you see it? I think somebody said that they thought that, yes, it does count, but I would have to go back and look and take a closer look at that provision.
Yeah, someone did say that in the chat box, and I know just from some of the research that I've done when you're filling things out, it seems to say you cannot have any sort of back child support that you owe.
Yeah.
All right. Moving on to our next question. I'm a grandmother and just got custody of my grandson. Will we be given extra money for him?
So that is unclear to me on how they are going to calculate those individual checks, but I think it would depend on your tax filing.
And I think there is a certain bump per child. I don't know how it works specifically with head of household, but I'm assuming it would work the same way someone married filing jointly would claim a child or dependent.
Next question, is Massachusetts negotiating for approval of the things they asked for that were not on the checklist?
Oh, that's a Rochelle question because she's involved in some of those conversations.
Yes. So right now, MassHealth is negotiating for the things that they asked for that they did not get approval of. They said scheduling with the Centers for Medicare and Medicaid Services is tricky right now, but they are, getting some time on the calendar to talk those things out. And I think, it seems like CMS is open to that.
And what are some examples of those things, Rochelle?
I want to say one of the things was expanding hospital presumptive eligibility to non-MAGI Medicaid populations. So the age blind and disabled category.
Yep.
It also seems like, though, that that's something a state could apply for through an 1115 waiver. And so I don't know if the question from MassHealth to CMS is that something we just need to put, is that a provision we need to ask for in a different application? Do they just make a paperwork error, or is it, does CMS not want to approve that for another reason? My understanding is that they will expand hospital presumptive eligibility to other populations like older adults or individuals with disabilities. So it's maybe just a matter of how they ask for that, how states ask for that.
Mm-hmm.
And this next question seems to sort of go along with that previous Massachusetts question. Someone asked, I read where the $1,200 counts for MAGI, but the additional $600 unemployment from the Fed does not. Is this correct?
Can you repeat that one more time? I was reading through questions.
Sure. I read where the $1,200 counts for MAGI, but the additional $600 unemployment from the Fed does not. Is this correct?
Rochelle, I'd have to go back and look.
Yeah, I don't know about the tax treatment of.
Yeah, I know the 600 definitely not. I need to go back and check the 1,200. But we can do that for you.
Are any states that have been resistant to Medicaid expansion getting closer to that?
Oh, this is really complicated. And I think, unfortunately, the Trump administration is working against us in the sense that, if you can cover the uninsured through a temporary vehicle, as lifted up by the second package, or using the 1135 that Rochelle highlighted, it certainly feels like less of an incentive, right, to close the coverage gap, which is the simplest and most direct way to help people access coverage and care, right? I think similarly, this morning we heard that the Trump administration is going to redirect some of the $2 trillion CARES bill toward an uncompensated care pool of some sort to reimburse states for some of the costs of treatment around uninsured instead of opening the federal marketplace. So I think the sabotage continues, and it's incredibly frustrating. I think our job is to continue to remind those that are working hard to close the coverage gap that the opportunity is there, and it's simple, and it makes the most sense to be able to help people in the immediate term as well as the longer term. What would you add to that, Rochelle?
No, I think that's exactly right. I haven't heard of any state who is more enticed or more interested in expanding Medicaid. The question of, are any states or could any states increase Medicaid eligibility, income eligibility limits at this time has come up a few times from different states. And so I was trying to look into, yes, if any state has taken it upon them to increase eligibility in any way for traditional populations. And it doesn't seem like it, maybe because it just becomes a state budget issue. But yeah, other than expanding presumptives and expanding just the home and community-based service waiver population, it doesn't seem like any state is going ahead and increasing the income limits, although that would definitely be a way to reach the remaining uninsured and make sure everyone's covered.
Next question, is there a good place to find 1115 or SPA for states? Person said it's very hard to find.
That is true. I agree with that person.
Yeah, they are very difficult to find. You can track at least whether or not states are pursuing the 1135, the 1115s. In this context, the Kaiser has a tracker that they're using, and the Center for Children and Families is getting ready to launch their own. And then, Rochelle, I don't know if you want to speak to just trying to generally track an 1115 of how much fun that is.
Yeah, for the 1115s that have come out specifically for COVID, I haven't found a great place with where they all live. I've been getting just email updates from people who are watching it as closely as me. And then state plan amendments too, I think in general are actually pretty hard to find. There is a location on the Centers for Medicare and Medicaid Services website, but it seems like states aren't required to post them, or I don't know. It just seems like that section of the website isn't as updated. It's really hard to find a Massachusetts state plan amendment.
Yeah, so with the SPAs, they don't have the same transparency requirements as the 1115s for public comment and such. And so, a state doesn't really need to share their change in their state plan amendments with you until they're final. And then usually you can find the approved ones, but you have to dig pretty deep. But as we identify new places that are collating this information, we'll be sure to pass it on and get it to folks so they can do some tracking. I wanted actually to just say a comment. I saw Steve's question about race and ethnicity data, and just wanted to take a second to lift up that as an important component, I think, as our push for Package 4, because we don't have enough data on how disproportionately communities of color and immigrant communities are being impacted. And we do know that they're under-resourced, and we're hearing stories about people lacking access to testing. And many of these folks are also essential workers and working the front lines. And so it's incredibly challenging to collect both the data, but also ensure that communities are getting the resources they need to access both the screening and the treatment that is needed to help keep them well and keep the community at large well. So I think that there will be a much stronger push, as there should be, around data collection so that we can begin to uncover what's really happening at the local level. And I think more importantly, that we ensure that we're not increasing disparities as we move forward in the work.
We have a few minutes left, so we'll answer as many more as we can. Can PE expand so that it is not limited to the month approved and the month following, so that it can be kept in effect until an application is approved or denied? And can the 12th limit be limited for time span from one PE to another?
So I have not heard about expanding the window that PE determinations become effective, although there is also Medicaid retroactive eligibility back to 90 days before the date of approval. But for PE, yeah, I have not heard of any states asking for changes on when the coverage takes effect. Danny, you cut out a little bit, but was the other question about getting more than one PE determination in a year?
Can it be kept in effect until an application is approved or denied? Can the 12-month limit be limited for time span from one PE to another?
So, yeah, Massachusetts and I think some other states have requested a waiver of the prohibition against getting PE if you've had a PE determination within a year. They are waiving that. I think some other states are as well. So that, yeah, if you've had a PE determination within a year, or I think if you were ever on Medicaid at any point within the past year, you can still get a new PE determination.
And another person asked if they're basing what you get from your stimulus check out of your tax return for previous year. If you recently got a new dependent in your home, will you get assistance for them?
My understanding is that it is based on, I think the check is based on your 2019 tax filing.
Yep, or
information.
2018.
So you do.
File.
So yeah, that's a good flag, because I myself am someone who gave birth in 2019. So if they were going based on my 2018 information, it wouldn't be accurate and would be, I would assume, less generous than it is now. So yeah, I think it's just whichever is most recent, which raises the question of, is it possible that someone was eligible for the check based on their 2019 income, or let's say they were ineligible, let's say they were ineligible based on 2019 income, but they're eligible now because they just lost their job. They might be out of luck.
Right. And I think they're still trying to figure out the details of how to do this, unfortunately, and so there's not a lot of clarity right now.
Great. Well, we are almost at the end of the hour. Let's see, we had one more question just come in. Ohio does seem to be waiving a number of things other states are getting waivers for, i.e. provider requirements, etc. Does anyone know how we're doing this, how this is done without a waiver? And the person says she's specifically referencing HCBS.
Did you catch that question,
Rochelle?
I
know someone earlier in the chat box too referenced that Ohio, but there were some 1135s from Ohio, and so maybe the Kaiser tracker is out of date. And I would guess that there are some home and community-based service policies or practices that you could change through an 1135 or just through guidance.
Right.
That you wouldn't necessarily need a waiver for.
This is Tara at Community Solutions. I just wanted to jump in there quickly. The references earlier to Ohio's 1135 waivers were for specifically the Ohio Hospital Association that submitted an 1135 waiver, as well as two of our sort of long-term care organizations in the state submitted a waiver, but not formally through our Department of Medicaid.
Gotcha.
And also, this is Danny. In the chat box, I did just share with everyone, one of our colleagues did write a piece on home and community-based service waivers in light of COVID-19. So it could be another resource for a person to take a look at.
Yeah, and I also threw in there, Danny, some resources on state. I know folks are really interested in how to maximize kind of what you're asking for as you put pressure on your administration to use these tools. So the toolkit I sent gives you a list of some best practices.
Awesome. Any final comments that you guys would like to leave everyone with today before we say have an excellent afternoon?
So I would just encourage folks that, you know, this is a confusing time when people are trying to operationalize these massive legislative pieces, and there's still not a lot of clarity about how they're going to play out in the state and on the ground. So as much as we try to provide you helpful information with what we know at the federal level, what you provide us with what's happening at the state and the local level is even more important to make sure it's guiding our advocacy in the right direction. So any of the feedback that you can provide us about where things stand or where you see holes or challenges is certainly super helpful. And we just really appreciate you and all the work that you do.
Yes, and please feel free to email us with any more questions. We'd love to hear from you.
Great. And Tara and Kelsey, not sure if either of you had any final comments for everyone who attended today.
This is Tara. I'll just jump in and say thank you all so much for joining us on this Friday afternoon. I hope it's sunny where you are too. And we are going to keep doing these on Friday throughout the next several weeks on various policy issues and how the pandemic is impacting access to food, Medicaid health care. We're going to talk with some state partners over the course of the next few weeks. So we really appreciate everyone from Community Catalyst in kicking this off with us, and so very much value all of the information that you provided today. Kelsey, any parting words?
No, thanks so much, Tara. Just a quick preview for next week. We will be looking at some of those more specific economic provisions and specifically unemployment in Ohio. We will be featuring our partners at Policy Matters Ohio. Zach Schiller will be on with us, and we'll be able to answer some more of those Ohio-specific unemployment questions. So we look forward to you joining us again next week, and thank you so much for your time. Enjoy the rest of your Friday.
Thanks, everyone.
Great. Thank you. And this presentation was recorded and will be available hopefully later this afternoon for everyone to take a look at. And with that, thank you so much for joining us for our first in our Friday webinar series. And special thanks to both Eva and Rochelle. And everyone stay safe, wash your hands, and have as nice a weekend as possible.
Thank you.